Hello, everyone. Welcome to the Chapter 10 of Healthcare Delivery in the United States, Healthcare Financing. Healthcare financing is a major influence on what services are provided and also how they are provided. Financing also provides incentives for improving quality, efficiency, and resourcing. So financing is not just something that we count, it's also a tool that can be used to change behavior and improve outcomes. The national approach to financing it's dynamic and it's constantly in flux, and that creates a lot of challenges for hospitals and clinics because they have to work to keep up with the changes in financing. And as I mentioned before in a previous lecture on healthcare and politics, there's also great variation in opinions about making healthcare more affordable. The next couple of slides will provide a general overview of healthcare financing. So financing generally refers to how we pay for care, who pays for care, transactions between users and providers, and how many total dollars are spent on care. Recall from other lectures that healthcare is really a unique industry and commodity. Unlike services like grocery stores, which virtually everyone uses, healthcare is used consistently by a smaller portion of the population. One estimate is that 20% of individuals use 80% of services. And these individuals tend to have multiple health problems and limited functioning, limited quality of life. As a result, treatment for this population is expensive. The insurance system is a major part of healthcare financing. Like other insurances, it's based on the idea of paying for services collectively, pooling our risk for healthcare. And so this allows us to pay for services from that collective approach. The individual pays the premium, premiums are pooled together. There are many types of health insurances. They can be paid through taxes, employers, or individuals, co-payments, and reimbursement can be quite complex depending on negotiated reimbursement rates. There are both public and private insurance programs. Public includes Medicare or Medicaid, and then private includes a number of private companies. And these two categories reflect that unique nature of healthcare as a quasi-public enterprise. At the heart of that nature is the question, is healthcare an economic commodity or an inherent right? In this table, you can see national healthcare expenditures measured in billions of dollars with a comparison of expenditures in 1970 to those in 2013, and then those projected in 2020. The cost of services has dramatically increased according to this table, but notice also the cost of administration has also increased, and that represents over $300 billion in costs. Currently, healthcare costs represent about 19% of the national GDP. The majority of these costs pay for personal healthcare services to individuals. We pay for healthcare through insurance, out-of-pocket cash, or maybe a charity or safety net providers as well. And recall from an earlier lecture that other countries use different funding streams compared to the US. Here you can see an illustration of the change in healthcare expenditures over the past several decades. And again, this emphasizes the point that expenditures have increased significantly relative to the gross domestic product. There are several public health insurance programs for a variety of groups: Medicare, Medicaid, CHIP, the Veterans Health. Public employees have access to their system, their coverage, members of the armed services and their families, and then Native Americans. Many individuals are covered by private insurance through their employer. Individuals who do not have that benefit may purchase insurance directly from the insurance companies or buy insurance through the insurance exchanges established by the ACA. It's important to know that the publicly financed programs are large, both in terms of expenditures and also coverage. Medicaid spends 64% on just a third of their enrollees. And remember that Medicaid is administered by the states, but funding comes from both the state and federal governments. Medicare includes multiple parts. Here you can see Part A, Part B, and Part D. And remember that Medicare is administered and financed by just the federal government. Other public programs include the coverage for active duty and retired military personnel. When I worked in Fayetteville, North Carolina, as a behavioral health provider, I treated active duty personnel and their family members from the nearby Fort Bragg military installation. And I was credentialed with TRICARE, which is one of their insurance plans. TRICARE, in my experience, was much easier to work with than private insurance companies. Okay, two more we have here. Indian Health Services, that covers eligible participants who are members of federally recognized Indian tribes and their descendants. And then workers' compensation is an insurance system designed to protect workers against the cost of medical care and loss of income resulting from work-related injuries. And workers' compensation is operated by the states. This figure illustrates where Medicaid expenditures go. You can see the program covers a high percentage of children and that most of the expenditures go to people with disabilities. Here it shows 42%. As mentioned before, employer-based insurance covers many individuals, and that started during World War II and covers fewer individuals today than it did in 2002. Individuals without employer-based coverage can purchase insurance directly in the exchange market, sometimes with the aid of federal subsidies. Now, the COBRA, the Consolidated Omnibus Budget Reconciliation Act, reduces the gap in insurance coverage between jobs, and employers must extend insurance for up to 18 months after an employee leaves. COBRA can be very expensive coverage, and it's really meant as a stopgap between jobs. The system for paying providers through insurance is complex. The public programs have fixed rates. Providers can accept the fixed rates or choose not to treat those individuals. There are some clinics, actually there are many clinics that no longer accept Medicare or Medicaid because of that situation. There is also negotiation between insurance companies and providers. Any provider that does not negotiate, physicians often at disadvantages unless they are organized into large groups. So if you have a clinic with perhaps just 1, 2, or 3 physicians, they are going to be in a lower power situation when it comes to negotiation. Other places like large hospitals, academic medical centers, they're going to have more bargaining power. And then any provider that does not negotiate rates with an insurer through a contract is considered out of network, and that can also be a disadvantage. Private insurers often pay the best rates, and that is one reason why hospitals and clinics prefer to have privately insured patients as much as possible. The other key source of reimbursement comes directly from the patients. So individuals without insurance pay cash, individuals who use out-of-network providers pay cash, and then they can seek reimbursement. The increasing number of physicians have decided to be out-of-network providers because it puts the financial responsibility more on the patient. And then finally here, price transparency is an ongoing issue. And when you think about it, there's really no other industry that is like healthcare when it comes to price transparency. Usually when you go to a store or to a car repair shop, the price is told to you up front. That does not happen often in healthcare. In the past few decades, new payment approaches have appeared in order to reduce the high rate of year-to-year cost inflation in healthcare, and also create incentives for providers to deliver higher quality care and to use more efficient practices to manage patient care. It's very difficult to find that elusive sweet spot where providers are delivering high quality care and needed services, but you also have those incentives for providers and patients at the same time. The biggest change in the privately financed portion of the US healthcare system over the last 3 decades is the shift toward various forms of managed care. And here are 2 of them. The first one are the prepaid health plans, HMOs, health maintenance organizations, which have been around for a long time. These focus on capitated payments, and they control which providers participate in their network. And then the second example of managed care are preferred provider organizations, where they encourage plan members to use a list of providers with whom they have negotiated discounts. The out-of-pocket costs are lower for the insured with a PPO. Consumer-driven healthcare is an approach to insurance that focuses on making consumers able to sense price signals when they purchase healthcare. In other words, can we make the consumer price conscious, price sensitive? And this usually requires a high deductible and putting more responsibility, more risk on the consumer. Here you can see reference pricing, and this is a form of co-payment that involves the payer exploring the range of prices charged by different providers for a specific service in a given community. And then the payer chooses providers with reasonable costs and good health outcomes. So they have to have both reasonable costs and good outcomes. And then based on that price, the payer then sets the price according to what they found, according to that reference price. So it involves doing some research. Fixed payment approaches are designed to increase efficiency and control costs, and they've been around for many decades as well. One type is the diagnosis-related group system, and this is in which a payer fixes a reimbursement amount for a specific group of patients. The second one, bundled payment rates, this expands on that idea of the diagnosis-related group system. It's where both the physician and the hospital are paid a fixed amount to provide an episode of care, or in the case of patients with chronic conditions, a specified time period of care. So it's a little bit more precise than the diagnosis-related group system. And we'll talk more about bundled payments in the Chapter 11 lecture. Overall, fixed payment approaches incentivize providers to limit healthcare utilization and minimize waste. Another example of fixed payment are the prospective payment rates for, resource-based relative value scale, or RVS. So Medicare programs approach to using standardized principles to set rates for different specialists and for patients with different medical needs. And the rates are determined through lots of research. And then also Medicaid has also established reimbursement rates that are often lower compared to other plans. So this is another reason why hospital, or at least clinics, are reluctant to accept Medicaid patients. And that is the end of this lecture.